Bismillahirrahmanirrahim. Welcome to the second session of Advancements in Neurosurgery webinar series. And this session is based on pituitary surgery. Pituitary surgery is something which is very close to me and has been, I think, over the past decade. The more you get to do it, the more you learn. And there are real experts around the world as well who are doing this surgery at very high standards. It all depends on the outcome of the patient, what it comes to in the end, especially in functioning adenomas. So as neurosurgeons, we've tried to excel and try and develop new techniques or use the old techniques, bring them into neurosurgery, and try to do endoscopic neurosurgery and try and produce the results which are beneficial to the patient. Now I've got two more panelists. I'm waiting for them to come because they've got clinics running at present, and they're about to come. One of them is, of course, when it comes to pituitary neurosurgery, you can't do it without an endocrinologist. You need a good endocrinologist, and alhamdulillah, at Shifa International, we've got two leading endocrinologists in-house. One of them is Dr. Osama. He is head of the department as well. He'll be talking about functioning pituitary adenomas. That includes Cushing, acromegaly, prolactinomas. It's of course a huge topic, but we are trying to get this webinar series in a way that we can, so that it's good for both the seasoned neurosurgeons in Pakistan or around the world, and also at the same time, residents and endocrinologists who are joining this session to try and propagate the knowledge and information on what to do and what to refer to a neurosurgeon or an endocrinologist. And considering we are working at Shifa International, which is one of the leading hospitals in Pakistan, and also we are, I think one of my panelists is here, speaker. This is Dr.Umar Yousaf Raja. Of course, I'll introduce him in a while as well. He's a very well-trained and experienced endocrinologist working with us. As a matter of fact, we both joined around the same time, Shifa International. He was also trained in United Kingdom and has got special interest, of course, in pituitary endocrinology. And he'll be talking about non-functioning adenomas, because we've got functioning and non-functioning adenomas or pituitary tumors that we tend to deal with. Some of them can be managed medically, some of them require surgery, and you have to work very closely with your endocrinologist to try and provide the care at a level so that the patient satisfaction is guaranteed, which is our motto anyway in Shifa International. I'm waiting for my first speaker, and the first speaker is here. I've already introduced you, Dr. Osama. I think, come around here. This is your chair. Okay. So as I was saying, Dr. Osama is here. He will be starting with his talk first. I've already introduced him. I don't think I need to introduce him any further. And without any further ado, we'll go ahead with the talk of Dr. Osama, which is based on functioning tumors.
Okay. Thank you, Dr. Akbar, for inviting me over here for another important CME on the very important aspect of endocrinology, that is the pituitary. You all know that the pituitary is one of the major endocrine gland. It secretes almost all the hormones that are essential for the normal human function, body function. So let's begin. I'm going to talk on the pituitary adenomas, which are actually functional. So nothing to disclose, no disclosure. So adenomas, you all know, are the common cause of pituitary hormone hypersecretion and hyposecretions. And broadly, on the basis of endocrine function, they are classified as functional and non-functional. So a tumor, basically, in the pituitary gland can have a different presentations. Like it can cause hypersecretion of one or more than one hormone, what we call it as a functional pituitary tumor. Sometimes, but it can cause other aspects like it can cause a large tumor can compress the normal function of the pituitary and can cause hypopituitarism, even one hormone deficiency or more than one, and compressive symptoms, especially the compression of optic chiasma and the development of visual symptoms, especially heminopias. Sometimes the bleeding inside the pituitary tumor causing apoplexy, that's an emergency. And sometimes, rather, most of the times, what we see an incidental finding in the pituitary gland, the MRI done for some other reason, and which showed actually a small pituitary tumor. So I'm going to talk on the basically the functional aspect. Dr. Umar would talk on the non-functional aspect of the pituitary tumors. Okay, before going further, just a revision regarding the normal working of the pituitary gland. You all know that it secretes different hormones. So growth hormone and the prolactin are the most commonest abnormalities what we encounter in these adenomas. It also secretes other hormones like ECTH, the corticotropin hormone, which actually controls production of cortisol, along with gonadotropins like LH and FSH, and thyroid hormones. You all know that. There's just a revision that how the pituitary gland actually works. It is a strong negative feedback mechanism by the target endocrine glands. So the pituitary gland, actually, the adenoma can be a smaller in size adenoma or a larger in size. What we call it as microadenoma, which is less than 1 centimeter, and the more than 1 centimeter is a macroadenoma. And sometimes we do encounter very large size pituitary adenomas, what we call as giant or aggressive adenomas. Broadly classified on the basis of pathophysiology and according to the cell types, they are somatotropes, they are lectotropes, they are corticotropes, cells which are present in the pituitary gland, thyrotropes, and gonadotropes, and some others. And the hormones that are produced by these glands are basically classified according to the endocrine function they actually have. Like adenoma, which actually secretes growth hormone, prolactin basically is a lectotrope. Adenomas, which actually secrete growth hormone, are somatotropes. And corticotrope adenomas actually secrete ACTH. And gonadotrope adenomas and the thyrotrope adenomas, they are very, very rare, and they secrete their corresponding hormones. Thyrotrope actually secretes abnormal ACTH, TSH. Another characteristic you can see over here, just a revision, the clinical syndrome produced by the somatotrope excess is basically in adults is acromegaly and in children is gigantism. The tumor cell types are usually sparsely and densely granulated GS cells. Lectotropes are another commonest cause of common causes of pituitary adenomas. They actually secrete prolactin, which causes galactorrhea, amenorrhea, and I'm going to in the next few slides. I'm going to describe this hormone as well. And the cells, the tumor types are usually the same as the sparsely granulated prolactin as well as densely granulated prolactin cells. Sometimes growth hormones co-secretes prolactin as well. So the patient would present with a combination of acromegaly and hyperprolactinemia. Other causes are other cell types are corticotropes, gonadotropes, and the thyrotropes, and they actually secrete their corresponding hormones. That corticotropes actually secrete ACTH and causes a Cushing's disease. Gonadotropes actually secrete FS and LH, and thyrotropes TSH, and as a result, they produce this clinical syndrome produced by these adenomas, are according to their hormone they actually produce. So I will actually, in this presentation, I will highlight our own local data regarding the adenomas. This is one of the study, I happen to be the principal author of this study actually. It was actually a study of around more than 3,000 patients, which are actually screened for the pituitary abnormalities. And out of them, 384 were actually selected, screened, and found to have some pituitary abnormalities. You can see the highest one in our case were actually macroadenomas, followed by normal pituitary, but they have endocrine abnormalities. Microadenoma are not far behind as well, and empty cella is not that much uncommon in our population as well. But most of the cases we actually encounter were actually having a large size adenomas. that is a macroadenomas. You can, if they are, I've classified them actually on the basis of macroadenomas and microadenomas, you can see, and the highest number of cases were actually non-functional ones, followed by the functional ones. You can see in the red box in the left-hand side, prolactinomas are highest in macroadenomas as well as in microadenomas, followed by acromegaly and then by Cushing's disease. And fortunately, we have two patients who have thyroidopenomas as well. That is TSH hypersecretion, but they were large size tumors, macroadenomas. In microadenomas, you can see prolactinomas were on the top, followed by acromegaly and Cushing's. Few cases were actually related to Cushing's disease were actually having a macroadenomas. So I'm going to discuss briefly about all the 3 or 4 these types of adenomas. I'll start with prolactinoma. Why? Because this is the most commonest one. Electrotropes actually secrete prolactin, and it is enhanced by dopamine and estrogen, inhibited by dopamine but enhanced by estrogen. So one thing to remember over here, that high prolactin doesn't mean that this is the cause of prolactinomas, because there are several other causes of high prolactin as well. Like PCOS can cause slight decrease in prolactin, along with hypothyroidism can cause hyperprolactinemia, stress, drugs, a lot of drugs which can cause hyperprolactinemia. So whenever a patient comes with high prolactin, it's not that you directly order an MRI. First of all, you take a detailed history to find out what's the possible cause of hyperprolactinemia in this patient. And then you go for an MRI if indicated. Because a lot of our patients actually are taking some drugs which can cause hyperprolactinemia. You can see the presentation depends on the type of patient you are dealing with, because the presentation can be different in premenopausal females versus postmenopausal females, and what about in the males. In premenopausal women, they present very, very early because of high prolactin causes suppression of gonadotropins. As a result, they develop menstrual abnormalities, especially amenorrhea and galactorrhea. So as a result of early presentation, most of these patients have microadenomas. In postmenopausal females, because of these ladies already have hypogonadism, so the presentation usually is quite late. And these usually, ladies usually come with macroadenomas, large size tumors, and galactorrhea is rare in these cases. While in males, they always present late because of the fact that males have late symptoms, usually don't care about their symptoms most of the time, because as a result of slight deficiency of testosterone, most of the males do present, but they usually present late. And majority of these patients, what we have seen in our population, are having macroadenomas. So if you categorize prolactin on the basis of levels of the prolactin, the value of the prolactin correlates directly with the size of tumor as well. A patient has a very mild hyperprolactinemia, usually below 50 nanogram. Usually these patients can have infertility, but most of them had no symptoms. Those patients have a moderately elevated prolactin, like from 50 to 100 nanogram. Usually in females, they present with amenorrhea and oligomenorrheas and infertility. While if the patient having a prolactin more than 100 nanogram, these usually patients have a classical symptom of overt hypogonadism, and these patients usually should have an MRI and should be screened for adenomas. And I've told you earlier that the association of the level of prolactin with the etiology. You can see if the level is quite high, usually these are associated with large site tumors, microadenomas. If the level is around 100, 120, 150, or usually below 200, microadenoma is the most likely cause. And sometimes we do encounter these patients who have a non-functional tumor, but still have a marginally elevated prolactin. What we call it as a stalk effect hyperprolactinemia. And ideally, these patients should not be treated as prolactinomas, because a marginally elevated prolactin with a very large tumor, either the patient have a hook effect of prolactin. I'm going to describe in the coming slide as well what's the hook effect, or that can be a stalk effect. In pregnancy, in stress and drugs, you can see the level of levels usually don't go above 200. One of the drug, risperidone, is a notorious drug. It causes prolactin more than 100. So a detailed history before ordering an MRE is essential. For example, if the patient is already on risperidone and the prolactin comes around 100, you can safely say that this prolactin can be due to this drug. If the patient can withdraw the drug and you repeat the prolactin after some time and the prolactin comes high again, then you can order an MRA again. In our population, in our patients, you can see prolactinomas were around 19 to 20% in macrodenomas, while in microdenomas, they usually are around 40%. So the patients who have a prolactinomas in microdenoma classes, more were the females, while in macrodenoma patients, more were the males. This is another study that was done by one of our colleagues, and you can see over here microdenoma and versus macrodenoma versus giant prolactinomas, usually which are more than usually 3 or 4 centimeters in size. And in males, you can see macrodenomas are much higher. They are around 52% versus 36 were the macrodenomas. Almost in this study, there's almost more or less both actually were identical. While in microdenoma population, more females compared to males, because in females usually present early compared to males. Yeah.
Welcome, Professor Theodore Schwartz. My name is Akbar. I'm the neurosurgeon leading all this webinar series. I'm myself following in your footsteps, endoscopic pituitary surgeon, minimally invasive neurosurgeon. This is Dr. Osama Ishtiaq. He's the General Secretary of Pakistan Society of Endocrinology, who's talking about functioning adenomas. And we've got Umar Yousaf Raja, who's a senior endocrinologist as well. So if you're okay with it, we'll continue with the talk. I just wanted to make sure we know that you're online and we'll get you on Zoom. Is that okay?
Yeah, of course. Of course. I'm enjoying the lecture. So please.
Yeah,
continue.
I'll get Dr. Osama to continue.
Okay,
please.
thank you. So I was talking about the prolactinomas actually, micro, macro, and the giant prolactinomas. So hook effect is the important thing we need to remember over here, especially if the patient is a large size tumor and the level of prolactin is not that much high. If the patient has a symptom of hypogonadism, galacturia, and the pituitary tumor is large enough, and still the level is not that much high, you ask the lab to do a dilution of this level, this sample, so that a true prolactin level can be attained. Because sometimes the prolactin concentration is so much high that the labs usually reports with low values, what we call as hook effect. But if you encounter after dilution, the level stays the same in the lower side, you can expect that this is a stalk effect rather than a high prolactin effect. Another condition is a macroprolactin. That's one of the large molecule, is a native prolactin that is bound to immunoglobulin G and a very large size. But this entity is not of any clinical significance. And usually these patients are usually misdiagnosed and are treated as ordinary prolactinemias. If you are of suspicion that this patient has a macroprolactin, you order the lab to get it pre-diluted, pre-treated with a polyethylene glycol. And that usually precipitates macroprolactin, and the true prolactin can be attained. This is the usual logarithm, how to patient who comes with high prolactin, what we need to do. Usually we repeat if the patient has a very mild level. You need to check for hypothyroidism, especially renal disease. High creatinine causes high prolactin as well because of decreased screens of prolactin. PCOS, pregnancy, you need to rule out first, and then then ask for the medication. And if the patient is then taking any medication which can cause high prolactin, and then with a good history, then you can order MRA pituitary, usually dynamic pituitary contrast. A patient can have a microdenoma or a macrodenoma, then do accordingly. Management usually depends on the type of patient you are dealing with. Most of the microdenomas do not need any treatment until unless if fertility is desired. In females who have a menstrual abnormality, have a very small tumors, do not need a fertility. Estrogen or combined estrogen with the progesterone is enough. In a symptomatic microdenomas, usually the goals of treatment is to control the prolactin, high prolactin, along with tumor size, regularization of menstrual cycle, fertility, and galacturia as well. While in large cell tumors, the idea behind is to decrease the size of the tumor with the medication. This is the one of the tumor that is actually usually we treat with oral medication rather than sending them directly to surgery. Like medical management, oral dopamine agonist is the mainstay treatment of all these micro and macroprolactinomas, especially even those patients as well who have a mildly visual field defect. Still, we treat them with dopamine agonists to see if the tumor size shrinks or not, instead of directly shifting them to the surgery. Because these drugs are very, very effective. We have Cabergoline, we have bromocriptine, and others as well. We commonly use either of them, but Cabergoline is much more effective and very easily tolerable. Usually a logarithm to start with a dopamine agonist if the patient has a controlled prolactin levels to continue treatments for a longer period of time. If the patient has a large cell tumor. If the patient is still unable to control the prolactin levels with dopamine agonist, you try to increase the dose. If the patient cannot tolerate it, if the patient still has a high prolactin, you try switching to another dopamine agonist. If the still patient is unable to control the prolactin levels and still symptomatic, then you can consider going for a surgery, especially if the patient has a large cell tumor. But in a patient with a microadenoma, there is no role of surgery over here. And if surgery done and still the tumor is left behind, you can consider going for a radiotherapy in this case. This is one of the local data. You can see within if the patient has a large site tumor, it shrinks rapidly compared to a small site tumor. If the patient has a microadenomas, you can see in this case, tumor size shrinkage is much more obvious in a large size tumor. Microprolactinomas, same as the giant prolactinomas compared to a microprolactinomas. So if the patient has a large site tumor, appropriate dose of dopamine agonist is quite helpful in terms of prolactinoma size reduction. But one thing to remember over here is that you need to continue the treatment for a very longer period of time, because what we have seen in our case is that usually the treatment doesn't stop in large site tumors. But in microprolactinomas, you can sometimes stop the treatment as well. Now, going for the second tumor that is very, very common in functional classifications, that is acromegaly. There is a somatotroph adenomas, that is growth hormone secreting tumors. You all know that is a hypersecretion of growth hormone and insulin-like growth factor, IGF-1, with the pituitary growth hormone by the pituitary tumor, and IGF-1 is the end product. And most common cause followed by prolactinoma. And why we are so much concerned about this disease, because the mortality rate is 2 to 3 times higher compared to general population. And average age of diagnosis is usually, average is 40 years. I'm coming to next few slides. What about in our cases? You all know that Andre the Giant actually had acromegaly as well. And this is the classical different presentation of acromegaly. You can see over here the facial changes over the period of time. Whenever a patient presents with acromegaly, that the patient would have a tumor from very longer period of time, and the patient usually presents, in our cases, in our setup, what we have seen in our clinical setup, that patients usually present very late. In the next few slides, I'll show you our data as well, how the patient presents in our setup as well. And it causes almost all parts of the body involved. You can see visual field defects because of large size tumor. Heminopias are very common. Prominent supraorbital ridges, large size nodes, increase in the size of hands and feet, and abnormal glucose tolerance, followed by diabetes and osteoarthritis, neuropathy, sexual dysfunctions, osteoporosis, osteoarthritis, and if they are co-secreted with prolactin, that can cause galactorrhea as well. And later on, cardiomegaly, hepatomegaly, and cardiomegaly itself can cause cardiac dysfunction and heart failure and cardiovascular disease and morbidity. That's the hallmark of acromegaly if left untreated. In our setup, you can see over here, the second most commonest cause of functional adenomas was actually acromegaly. You can see 17.6% of the patients were actually having a macroadenomas, while around 14% actually had microadenomas. You can see over here, I've told you earlier that most of our patients present usually late, and most of our patients had macroadenomas. This is another study that was published in 2014 by Chandna Group. You can see pre-op growth hormone levels. They're actually IGF-1 were not available at that time. You can see pre-op growth hormone levels were done in this study. Majority of the patients have macrodenomas. And the level of pre-op growth hormone levels was much higher in macrodenomas compared to microdenomas. The age of duration, usually ages were around 31 to 45 years. Ranges were mentioned over here. Average, as told you earlier, around 35 to 40 years was the average one. And duration of symptoms were around 2 years in large size tumors, while in 5 years in small size tumors. The patient who presented early were lucky enough because they were treated much effectively with surgery in microadenoma groups. I've told you earlier that the impact on survival, the patient who has an acromegaly along with a cardiac disease has a much shorter survival compared to general population. How to diagnose acromegaly? Diagnosis is not much difficult. Clinical history examination followed by visual field testing to assess what's the degree of amyotrophy patient has, and then followed by IGF-1 level. Remember, the IGF-1 level varies from age to gender. So you need to see the correct IGF-1 level in your case. And if the IGF-1 level comes high and the patient has a classical history of acromegaly, we tend to skip this oral glucose tolerance test. But sometimes this test is very, very helpful as well. And growth hormone, 75 gram glucose and growth hormone done after 120 minutes, if less than 1 is termed as normal one. If the failure of suppression of growth hormone below 1 microgram, that is termed as diagnostic. And followed by imaging. Usually we don't order a single growth hormone level because it has no value in the diagnosis, but a single value of growth hormone sometimes helpful in the post-op period as well. So treatment is not the solo one. It needs a multidisciplinary approach. Endocrinologist, along with neurosurgeon, nuclear medicine, and all this combined to treat this important medical condition. Just a revision, how to confirm the diagnosis: start with the IGF-1 level, followed by glucose tolerance test, pituitary MRI, and visual field testing if compression of optic nerve is visible, and then the treatment. So treatment is basically surgery. The treatment of choice is surgery. A good neurosurgeon is very, very essential for all patients who are having acromegaly. But what happened in our case? Why? Because the treatment sometimes is very, very difficult. Why? Because of the fact that patients present with very large macroadenomas. So it is very difficult for surgeon to remove all of the macroadenoma in one go. The cure rates are basically good in microadenomas.
Ted, we'll have your opinion on this one later on about macroadenomas and how do you manage all these in a second.
Okay, this was our data actually, as you can see over here. The cure rate in macroadenomas was around 32%, while in micro it was almost 100%. That was the data in a well-established endocrine and neurosurgical unit in Pakistan in Khan University. That was a sample. The sample size at that time was around 30 patients, and now we have a much higher sample size in our patients, and still in the process of publication. But the results are not good in macroadenomas, unfortunately. And usually these patients were later on starting on medical treatment and radiotherapy as well. So what medical treatment we have so far we can offer to the patient is a dopamine agonist, that is Cabergoline, not met effective drug in these patients. Few patients respond to this drug, majority do not. Good drug is somatostatin analogs and growth hormone receptor agonists. We don't have Vesomine in Pakistan, but we have octreotide LAR version in Pakistan. Is very effective drug, but the cost of this drug is considerably high in our population, and not every patient can afford this drug. So what we have option for the patients? Those patients who cannot afford somatostatin analogs, we have an option to start them on dopamine agonist, that's Cabergoline. And if the patient does not respond to this Cabergoline, then the treatment in our population is radiotherapy. Radiotherapy is a good treatment, especially in our part of the world. Why? It's cost effective. It's usually the median time is usually 3 to 4 years, even more than that, most of the cases. And these patients usually end up in hormone deficiencies, like some patients develop hypopituitarism as well. So that's the treatment of choice in most of the patients, what we treat over here, especially in macroadenomas. Coming to the pituitary Cushing, just few more slides and then I'll stop my talk because two major hormones I've covered so far. Cushing disease as acid-secreting adenomas are more common in females, usually third, fourth decade is their presentation. In our population, around microadenomas are commoner compared to macroadenomas. 90% are microadenomas. Presentation, just a revision for all of us, especially one of the major causes of hyperglycemia, hypertension, fluid retention, obesity, stria, thin peripheral extremities, proximal myopathy, osteoporosis, and a lot of other changes. Especially those patients who present with suspicion of Cushing's should be evaluated for this disease because it is treatable disease. In our population, you can see it's more common in microadenomas compared to macroadenomas. Almost in this study, 18% of the patients were actually having Cushing disease in the microadenomas. This is our hospital data of 31 patients, not published so far, but I've brought the data over here. You can see in 31 patients, pituitary you can see was the commonest, followed by ectopic and then the adrenal. These pituitary were actually confirmed by IPSS, inferior pectoral sinus samplings. Another presentation you can see, I've divided these patients into those who are having a adenoma size less than 6 millimeter, those who have a adenoma size of 6 to 9 millimeter, and those who have an adenoma more than 10 millimeter. Those who have an adenoma less than 6 millimeter are much commoner compared to those who have adenomas more than 6 millimeter, but few of our patients having an adenoma more than 1 centimeter, they are actually classified as macroadenomas. The algorithm is more or less, I'm not going to in detail, but to start with a screening test, overnight DEXA suppression test, or a 24-hour urine-free cortisol, or a midnight salivary cortisol, followed by a confirmatory test like a low-dose DEXA suppression test, and then an ACTH. If the ACTH is more than 10 or a 15, then that confirms ACTH dependent Cushing disease. And you order an MRI, and an MRI shows an adenoma. You need to confirm the adenoma whether this is producing ACTH or not. Usually what we order are inferior pectoral sinus sampling because the high dose DEXA suppression test has a low sensitivity specificity. And if the inferior pectoral sinus sampling confirms pituitary Cushing's, then you order a surgery. Those patients who underwent surgery are evaluated for the cure, basically. If the patient has a drop in the cortisol levels, usually below 1 or even below 1.8, then we call it as they are cured or they are in remission, basically. Those who are not cured, repeat pituitary surgery can be option or followed by a drug treatment. And if nothing works, then you have an option to go for a bilateral endocrinology. At the end, just one slide on, one or two slides on thyrotropinomas or TSS secreting tumors and gonadotropin hypersecreting tumors. Thyrotropin adenomas, I happen to see two of them because they are very, very rare. In our study, around 1% were actually, two patients were having thyrotropin adenomas. These two adenomas are large-sized adenomas, and they actually co-secrete other hormones as well, like growth hormone, prolactin, sometimes gonadotropins as well. Presentation is usually around 9 years, and they present with symptoms of hyperthyroidism. But the thing, very important note over here is that the TSH stays usually in the normal limits, but the free T4 and T3 goes up. You need to order some other hormones along with an alpha subunit and SHBG as well, because you need to differentiate between a thyroid hormone resistance or a thyrotropin secreting adenomas. Treatment is usually somatostatin analogs, and fortunately, 90% of them respond. There's some role of surgery and radiotherapy over here as well. Since they are so much rare, so we don't have so much experience treating these disorders. Gonadotropin secreting hormones are also very, very rare, and we have encountered some of our patients. Usually the presentation is usually large mass effect, visual symptoms, hypogonadism, amenorrhea, and sometimes hypopituitarism as well. So just like other adenomas, you tend to investigate them as well. And you need to differentiate between non-functional versus gonadotroping adenomas. So at the summary, just before conclusion, whenever you encounter any pituitary adenoma incidentally discovered or a patient presenting with the symptoms, you are after a good physical examination, a good history, order all the pituitary profile and an MRI. If the patient has a hypersecretion, you classify it as functioning adenomas. And the most commonest cause of functioning adenomas are basically acromegaly, GH secreting adenomas, or a prolactin secreting adenomas. And they are non-functioning, you classify on the basis of their size, micro and macroadenomas. I thank you all for your attention. Thank you so much.
Okay, I'm going to present on non-functional adenoma, and yes, I'm going to be quick. Now, I have no disclosures for this presentation. So let's start with a case discussion. It's something that I've seen about 7 to 8 years ago. There was a 5-year-old gentleman who presented with 6 to 7 month history of erectile dysfunction, gradual in nature. There was occasional headache. His general practitioner did a prolactin level. It was 636 milliunit per liters. For those who are aware of microgram per deciliter, divide that by 18 or 21. Testosterone level was 12.7 nanomoles per liter, and MRI pituitary was showed 2.4 by 2.7 centimeter microadenoma with abutment of optic chiasm, later spraying of carinous ICA, and partial encasement of left ICA. And hence he was referred to my endocrine clinic. And here you can see the pictures. And if you can see the surgical section, you can see the adenoma here. And the corner section is not that good, but you can appreciate the levels as well. So here, if you can see, sort of basically the tumor there. So, of course, the working diagnosis was non-functioning pituitary macroadenoma with stalk disconnection. We did the further workup, including the anterior pituitary functions. And again, the morning testosterone came back slightly low this time at 9.8 nanomole per liter, with slightly raised prolactin level 487 milliunit per liter. TFTs was fine. He passed his short stacking test with 30-minute cortisol level 793 nanomole per liter, and visual fields were normal. And he was then referred to neurosurgery for transsphenoidal resection of macroadenoma, following which he was started on hydrocortisone for 6 weeks. And then a synactin test was done 6 weeks post-operatively and was stopped because he passed his short synactin test. Histology confirmed gonadotropinoma, and repeat MRI showed complete section of pituitary adenoma with normalization of optic chiasm and pituitary stalk. So he's currently having his yearly MRI for 3 years, followed by 2 yearly afterward and a yearly visual field checks. So what are the non-functioning adenomas? I think the new name for them are pituitary neuroendocrine tumors, or PITNET. So these are, and again, there's a debate going on whether we mention them as a PITNET or keep the old name as non-functioning adenoma. So these are benign pituitary neoplasm arising from the adenohypophyseal cells, and they are not associated with clinical evidence of hormonal hypersecretion. So clinically, they are silent. Important things are that this is a heterogeneous group, and you can classify them as per the hormone produced, such as null cell adenoma, or most of them are actually producing beta units of SHH, LH, or alpha subunit, so-called gonadotropinoma, so FSH, LH adenoma, or they can be silent tumors producing ACTH, growth hormone, or prolactin. Another way of classifying them is according to transcription factors. Of course, you can't do that in Pakistan. We don't have genetic testing here, but in the Western countries, you can classify them according to transcription factors such as PIT1, GATA2, or ER alpha. Now, Dr. Osama have already mentioned about the local prevalence data, but if you look at the Western data, the prevalence is around 22 per 100,000 population, more common in men, so 66% in men as compared to women. And again, the age of diagnosis is 50 years in men and 42 years in women. And the mean duration or the middle range of before you can diagnose non-functional adenoma is around 8 months in men and 9 months in women, though the range can be as high as up to 8 years. And again, on the right-hand side here, you can actually see now in the Western world, it's actually non-functional adenomas are much commoner after the prorectinoma. In our data, I think non-functional adenoma was the most common. But looking at the age of the presentation, so majority, around 78% presented between 20 to 60 years of age, a small proportion in a younger population group, so between 0 to 20 years, and then around 17% presented between age 60 to 90. So mostly they presented with mass effects such as hypopituitarism, headaches, visual field defects, cranial defects, and if they are very large, and I've seen few of them that have actually gone up to temporal lobe as well, they can cause seizures. They can also found incidentally, apoplexy rate is however rare, and I will come to that later on as well, but in one case, it was 6.2 cases per 100,000. So the main thing to differentially diagnose them is from prorectinoma. So if majority of them present as a macroadenoma in imaging, if biochemically confirmed there is no hormonal hypersecretion, then of course surgery is the next step after multidisciplinary meeting or discussion. But if prorectin is high, then differential diagnosis from microprorectinoma, these are the ones that you can actually offer treatment, medical treatment for them. And if you look sort of basically this study from Shifa law, there's no significant correlation between serum prolactin level and MRI features such as size and degree of pituitary stalk, compression or deviation in non-prolactin secreting adenomas. However, the case series in late 80s have actually shown that usually prolactinomas will have prolactin levels more than 6,000 to 8,000 milliunit per liter, whereas the non-functional adenomas will usually have prolactin levels less than 2,500 to 3,000 milliunit per liter, whereas in between these two limits, around 12% will be non-functioning adenoma. And here you can see the data from Nikki Karavitaki when she was in Oxford, and she actually looked at 226 patients with non-functional adenoma, which was showing supracellular extension. 41 of those patients were on medication, which was able to increase serum prolactin, and she found hyperprolactinemia in 39% of patients. But if you look at especially more than 2,000 milliunit per liter, then that was found in around 1.3% of total group, and these are all patients with the non-functional adenoma. So how to differentially diagnose them? It might be worthwhile to consider giving a trial of dopamine agonist. What you're looking for is a size or rate of tumor shrinkage as well as time under achievement of normal prolactin. So as Dr. Osama mentioned earlier, most of them will be found as pituitary incidentaloma. So if you find pituitary incidentaloma, if they are microadenoma, then investigate for pituitary hyperfunction. And if they are hyperfunctioning, then treat according to the hormonal subtype. But if they're non-functioning, then observation can be an option. On the other hand, for macroadenomas, you again investigate them for pituitary hyperfunction and visual abnormalities. And again, if there's endocrine or visual abnormalities, you can treat, but if there's no observation, you can still closely observe them. So management options does include observation as well as surgical removal, external irradiation, and medical treatment as well. So looking at natural history for the observation, I think for most of the microadenoma, this is again a study from Nikki Karavitaki, who look at 16 microadenomas, follow them up for a mean of 41 months with a range between 8 to 128 months. And you can see that most of them actually doesn't grow in size. So as far as microadenomas are concerned, you can follow them and observe them only. Macroadenoma is a different picture altogether. So again, if you look at the Nikki Karavitaki slides, out of 24 macroadenoma that she observed for a mean month of 43 months, around 50% there was an increase in size, and it took mean time of detection of increase in size was around about 36 months. Around 33% was stable, but there was small proportion. So around 16% there was a decrease in size as well. And the mean time of detection of these adenomas, where there was a reduction in size around 26 months. And most of them extend superiorly to the supracellular and quenous sinus. And the new or worse visual defect were found in 67% macroadenoma with enlargement. Again, sex, age, visual field defect, or Quellner sinus invasion representation is not predictor of enlargement. So the even rate for tumor growth per 100 patient per year was for macroadenoma is 12.53 with a constant interval between 7.86 to 17.20, and for microadenoma is 3.32 with a CI interval of 2.13 to 4.50. However, apoplexy is quite rare. So for macroadenoma, there was only 1.1 event per 100 patients year. So based on the natural history, again, you can make the management protocol. So if they are microadenoma, you can assess them clinically yearly, and MRI can be done in first year and then within 5 years. And if they are fine, then you cannot also think about discharging them. On the other hand, if it's a macroadenoma and you're not planning surgery, then they need to have clinical assessment yearly, visual fields yearly, and if it's so close to optic pathway, and MRI 6 months, and then yearly for 5 years. And if there's an increase in size, then surgery is the key. However, if they have got other comorbidities, then you can closely observe them. But the macroadenomas are one that I never discharge them. So post-operatively, the mass reduction lead to resolution improvement, headaches, improvement normalization of visual field up to 80%, improvement pituitary function. So there's a various criteria. If you look at FSH, LH, about around 33 to 42% will show improvement. For ACTH, 36 to 67% will show improvement. And for TSH, they have improvement between 34 to 72%. But there are small proportion where there's a worsening of pituitary functions as well. So once you have offered them surgery and they had their surgery, what's next? There's no randomized controlled trial on the use of adjuvant radiotherapy. But if you look at retrospective studies, and again, these are Kaplan-Meier curves, and here you can see that if in all patients, if you offer them radiotherapy, then the progression recurrence-free rate in those patients are actually 0.8 with radiotherapy as compared to 0.5 with radiotherapy. However, if there is a residual macroadenoma, then if you don't offer them radiotherapy, then around 80% of them will recur within 10 years as compared to only 40% with radiotherapy. So again, then based on the retrospective data, you can, after surgery, you can offer them MRI at 3 months. If there's no residual tumor or intracellular residual, then annual MRI for 5 years can be done, followed by biannually with visual field assessment. However, if there's significant residual, then you might offer them adjuvant radiotherapy. The other important thing that I notice here is Ki67 index. So if it's Ki67 is above 3%, then normally I offer them adjuvant radiotherapy. What about medical treatment? Now, dopamine agonist can be used. It's because the non-functional adenoma express DA receptors. The short-term studies have shown a shrinkage rate of 27% and enlargement in 8.5%. However, for residual tumor, the shrinkage was seen in 45 to 56% of patients and enlargement in 10 to 33% of cases. So what's the rationale behind dopamine agonists? We know that in vitro data have shown that dopamine agonist treatment reduce gonadotropin subunit secretion as well as inhibit thymidine incorporation in 2/3 of non-functioning pituitary adenoma. Small series have shown bromocriptine reduce in tumor shrinkage. There is a modest shrinkage in comparison to the exuberant effect that you see in prorectinomas. So basically the rationale here is that we don't need shrinkage, we just need enough. So there is no pressure effect, especially in those patients where there is a lot of comorbidities and surgery cannot be offered or radiotherapy cannot be offered. So here you can see this study from Greenman published in 2016, where they look at 79 patients with macroadenoma, 96% have supracell extension, 60% Cabergoline sinus invasion, and they were either given preventive treatment where dopamine at around about 2 milligrams per week, Cabergoline was started after post-operative MRI, or remedial treatment where they were initiated after detection of tumor growth, and then they were compared with a control group from another medical center and were followed up for 8.8 years. And here you can see that growth prevention was achieved in 58% of tumor with documented tumor enlargement prior to treatment initiation. So the negative predictor for response was male, young age, and preoperative tumor diameter. And then if you look at the case series reports, around of total, I mean, these are small case series reports, but out of total 123 patients, 40% shows shrinkage, 41% shows stable growth, and 18% shows an increase in the growth. The other medical treatment that we can use is somatostatin analogs. So here, sort of basically, you can see that non-functional adenoma express mainly somatostatin 3 receptors followed by SH2 and SHT5. And we knew that octreotide act mostly on SH2 and some effect on SHT5. So not surprisingly, if you look at the short-term clinical trial, the shrinkage in only 5%, whereas enlargement in 12% of cases. So to summarize, I have just discussed about the differential diagnosis between colorectinoma and non-functioning adenomas, management of incidentally found non-functioning adenomas, and management strategy after surgery. I think we need to think about other perspectives, such as we need control studies for optimal therapeutic strategies. What are the prediction markers beside Ki67 for tumor biological behavior? And what about think about the improved result of initial neurosurgical deburking?
I'm just looking at the questions. I think one of them is for Dr. Osama, and that's from Manchester. This is, I think, Inam. He's asking, like, what sort of mechanism is in place in terms of follow-up for patients with functioning pituitary tumors following surgery at Shifa?
Well, we have a well-established endocrine unit over here, and we usually monitor these patients regularly, just like a protocol that has been well established elsewhere in the world as well. So all the functional adenomas, no matter whether they are colorectinomas, Cushing's disease, acromegaly, they have a regular follow-ups as advised by as done in the rest of the world as well.
I mean, this is Shifa International, and we are like the leading institution of Pakistan. So we provide the care at international standards. That's what we are aiming for and we are doing. There's a question for Umar. How confident you are for reliability of SST 6 weeks after pituitary surgery instead of ITT?
Yeah, I mean, I think sort of basically a lot. I mean, this is the protocol that we used to follow at Queen Elizabeth Hospital in Birmingham. And there, initially within 6 weeks, you need to think about the ITT. But after 6 weeks, if they have got what you can say ACTH axis involved, then the adrenal gland will be atrophied enough that SSTs you can use short synaptin test after 6 weeks. So in Queen Elizabeth Hospital, we used to do short synaptin test after 6 weeks, but definitely within 4 weeks, insulin tolerance test is a better approach. However, in Pakistan, we don't have short synaptin test anyway. Mm-hmm. So normally we decide on our morning cortisol levels, and it's always, I mean, I always, if it's above 10 microgram, 11 microgram per deciliter, then I think about stopping the data cortisol is what we tend to use, or prednisone is what we tend to use here. Otherwise, I am a bit more cautious, and if it's less than 10, then I start them with 2.5 milligram of data cortisol, and then repeat the short synaptin test on a regular, the morning cortisol levels on a regular basis.